Okay, good morning, everybody. I'd like to start by thanking Dr. Siegel and Dr. Hamlin for inviting me to speak today. I was just talking this morning and saying what an amazing day this is, what an amazing lineup of speakers, and to see all of you here from multiple different state organizations. I kind of feel like this is what we need to do in every single state, to really advocate and develop programs for individuals with autism and developmental disabilities. So we've heard quite a bit about the complexity of psychiatric diagnoses, about how to make a diagnosis, all the different influencing factors involved in making a diagnosis. Today I'm going to talk about one particular psychiatric condition, and that's anxiety. And my goal today is to take all this complexity that you heard and try to boil it down and give you some nuts and bolts and some concrete anchors that you can hold on to when you think about anxiety in working with children, adolescents, young adults, and in understanding the cases you see and thinking about the services that an individual needs. I see a lot of kids, adolescents, and young adults with anxiety in my practice, and parents and caregivers are saying that the anxiety is so persistent and so debilitating, more so than the autism symptoms themselves. I have no disclosures to report. So at the end of my talk, I hope you'll be able to recognize the high prevalence and impact of anxiety. What I want you to walk away with is currently we conceptualize anxiety as a separate and distinct mental health condition from ASD. And I'm going to talk to you about the different manifestations of anxiety that present in youth with ASD. So this includes more traditional anxiety disorders you may have heard of, social anxiety, generalized anxiety, but also more specific, unique forms of anxiety that are special and manifest in kids with ASD. And then I'm going to give you some guidelines about how we think about assessing and treating anxiety in the population, given where the research is so far. So this is Dr. Lee O'Connor. He is an Austrian child psychiatrist. He came to the US. He opened the first child psychiatry unit in the country at the Johns Hopkins Hospital, and that's where he first observed 11 cases of children with autism spectrum disorder. And he vividly described all the criteria for autism when he picked up on this very unique phenotype. And he also was the first to say that he thinks this condition is innate and it's genetic. So in his early vivid descriptions about social cognitive impairments, repetitive behavior, he talked about anxiety. So he wrote a 1943 paper, and he described these 11 cases, and in his earliest phenotyping of these cases, he talks about idiosyncratic phobias, fear of mechanical things, fear of changing things like the wind and large animals, fears mainly of mechanical noises, of running water, gas burner, and many other things. And so these are the unique phobias that he picked up in kids with ASD, and that was in 1943. So in 1980 is when autism made its first debut into the DSM, and this is the DSM-3. And if you notice, anxiety is one of the criteria. So at that time, people were thinking, oh, anxiety is part of this phenotype of autism. It's universal. Every person has it. Sudden excessive anxiety manifested by such symptoms as free-floating anxiety, catastrophic reactions to everyday occurrences, inability to be consoled when upset, and unexplained panic attacks. And if you go down further, number 7, another psychiatric condition was also mentioned, and that's self-injury and self-mutilation. So decades ago, we thought that all these psychiatric conditions were part of the autism. But our understanding has really changed. And this is a graph showing the explosion of research on anxiety in children, adolescents, and young adults with autism. And you can see 1980 was the DSM, 80s, 90s, early 2000, hardly any research. But in the last 20 years, it's really exploded. And there are groups around the world just studying different aspects of anxiety in individuals with ASD, what it looks like, how to measure it, what causes it, and how to treat it. And one of the most important things we've learned is that the anxiety in this population is extremely prevalent. So in child and adolescent studies, if you look at the meta-analysis conducted by Van Stiesel et al., about 40% of children and adolescents have an anxiety disorder. Now, they had a specific way of pooling all these studies together, and the measurement of anxiety was different across studies, but I want you to take away the high prevalence. And Siminoff et al., this study was presented earlier by Dr. Lerner, 44% of kids had an anxiety disorder, so very prevalent. And in adult studies, 39%. So the base rate in the general population, 12 to 20% of kids and adolescents will have an anxiety disorder at some point in development. 18% of adults will have an anxiety disorder. So this is really double the population. And what we know is not only is it double, but this gives us some support that it's not part of the autism. It's not universal. It's not ubiquitous in every single individual we see. So it really is separate. It's distinct. It's a separate mental health condition. And it's a lifespan condition. So we see it when the kids are young, and we see it in adulthood. And in my practice, I'll see kids as young as 4 years old, and the parents are coming in because of the anxiety, right? The kid's already hooked up into early intervention, speech language, OT, and so on and so forth. But they're coming in for treatment for anxiety. And how does it manifest? It manifests as tantrums. But I also see kids who haven't had anxiety for a while, and then in 7th grade, something changes. The demands exceed capacity, and boom, here comes an anxiety disorder. So anxiety has a major impact on functioning. It makes all the ASD symptoms worse. Social skills are more challenging. Repetitive behaviors increase, rigidity, vocalizations. It interferes with ASD-specific treatments. So we will often get calls from speech and language pathologists and behavioral psychologists. Help us, we can't do our work with these children. We can't work with the adults because the anxiety is too high. We can't have them participate in speech or other treatments. It increases family stress, and it influences the transition placement from adolescence to young adulthood. So we think that when we plan for life after 21 is about autism, more often than not, it's about the mental health conditions, and anxiety is the #1 condition to think about. And even in adults, occupational stress, anxiety is a major problem. So I see lots of young adults. They go to one job, the anxiety is so high, there's no job coach on site, there's no support there for them. They leave, they go to another job, they leave, another one, and they end up sitting at home. Independent living causes a lot of anxiety. And then there's a lot of anxiety just socializing and making friends. So it's really a major, major problem. So this is Temple Grandin, leading scientist and advocate for individuals with autism. She herself has autism, and she suffered with anxiety her entire life. She says, "I was terrified of new places, people, everything. Fear is the overriding emotion in autism. Loud noises, including bells, would trigger awful panic attacks for me. When puberty hit, that's when the anxiety attacks and the panic attacks started. I was the type of person with autism where once there was puberty, nonstop panic attacks. I mean, imagine how you felt when you did your first really big, important, interview, how nervous you were. Now imagine if that's the way you felt all the time. And at that time, she took a medication called imipramine, which is one of our older medicines. But she realized she could not manage this anxiety on her own or with psychosocial supports and services. And she was a strong advocate for taking medication to help relieve some of these symptoms. The other thing I wanted to mention, going along with some of the physiological work that was mentioned earlier, is that anxiety may be associated with increased allostatic load. So allostatic load refers to the amount of stress that's placed on your body, right? We like to think that our body and our mind are in balance and that stress is at a regulated level, what we call homeostasis. But there's a lot of work being done on the impact of stress, and this work is done by Bruce McEwen at the Rockefeller Center, a neuroscientist, and he states the wear and tear on the body, which grows over time when the individual is exposed to repeated or chronic stress, is the allostatic load. And if you think about individuals with ASD, all the criteria of autism make it very difficult to live in our everyday world, right? Our world is unpredictable, noisy, unstructured most of the time, and it's social. We interface with people all the time. And when you have autism, those are your major challenges. And so every single day becomes difficult. High arousal, high stress, and for many, a lot of anxiety disorders. So now I want to move on to what anxiety can look like in this population and how it could be different than in typically developing kids. Now this is a very complex condition to diagnose, so I am going to try to deconstruct it and simplify it and give you some kind of guidelines to think about. So the first type of anxiety that we talk about are categorical anxiety disorders. So these are the disorders that are in the DSM, right? Social anxiety, generalized anxiety, and so forth. And then the second type of anxiety that I'll discuss is atypical anxiety. And Dr. Lerner mentioned this morning. And these are the anxiety symptoms that are very unique to individuals with ISD. So if we look at the DSM anxiety disorders, there's a lot of work being done showing that individuals with ASD do experience anxiety disorders that are consistent with the criteria in the DSM. And you know, the 40% prevalence that I was talking about is based on DSM anxiety disorder diagnoses. So social anxiety, very common, especially in those with high intellectual, average to above average intellectual functioning. The hallmark here is worries about how you're being judged, whether you're being judged, feeling that people will, you know, hear what you're saying and laugh at you. So this anxiety disorder is reported by individuals who are high functioning, right? They actually say, when I go to a group, I'm very scared. I don't know what to say. I think people are going to laugh at me. So they have that insight, right? They do have that insight that they're being judged, and they are aware that they don't have the skills to navigate a situation. So I want to emphasize that individuals with ASD have social deficits and social impairments, but they can also have social anxiety. Generalized anxiety is also common. Individuals with ASD have a number of worries about physical threat, social threat, things going on in the world, things going on in their body. And some of them can actually report worry. So we talked about the ability of individuals with ASD to self-report. Some of them can self-report. You know, they might not be able to elaborate, but they can say, I think about this all the time, and it makes me scared. Separation anxiety is a more behavioral diagnosis, so you don't have to think about worries as much. It's about fear of being away from home or a safe place or a loved one. And I've seen this in kids who are lower functioning and higher functioning. I think of a 19-year-old guy that I see who developed separation anxiety, follows his mother everywhere. The parents are divorced. He started saying, no daddy, no daddy, no daddy. The first thing we think about is there abuse going on? Is there a situation here? Nothing. He developed intense separation anxiety, needed to be with his mother. When his mother drove him to school, he wouldn't get out of the car. The school staff worked with him to get him out of the car, and what happened? He exploded. He became aggressive, self-injurious, bit the staff, and the police were called. So separation anxiety can lead to self-injurious behavior and involvement of acute care systems. It can manifest in kids and young adults on the spectrum. It can also manifest in kids who are higher functioning. Specific phobias, we talked about idiosyncratic phobias, but also the usual phobias, you know, that kids have: heights, spiders, blood. OCD, a very difficult diagnosis to make. I probably have seen a couple of cases of real OCD, but again, difficult to disentangle the repetitive behavior. And traumatic stresses and traumatic stress disorders are now also gaining a lot of attention. And that's one of the reasons is because of the very high prevalence of bullying in this population. So about 45% of kids on the spectrum have been bullied at some point. So we're seeing a lot of acute stress disorder and post-traumatic stress disorder. So these are the categorical diagnoses. And they do manifest to some extent very similarly to as reported in the DSM. So the unique types of anxiety are what we call these ambiguous anxiety-like symptoms. And Connor Kearns has done an enormous amount of wonderful work on trying to phenotype and characterize these unique symptoms of anxiety that are present in individuals with ASD. And so these are anxiety symptoms that are wrapped around the autism. So every one of those autism criteria can be associated with an anxiety symptom. The reason we're separating it out is because they're not formally coded in the DSM, and we're figuring out how to code them. But it is important to be aware of them. So examples are fears and worries about unpredictable social environments. So In social anxiety, you're actually going to have the worry and the thought about being judged. Some kids with autism don't have that worry about being judged, but they go into a social situation and they freeze. They don't know how to navigate it, they don't know what to do, and they don't know what's going on. So that's unique to ASD. Fear and worry about rules, schedules, or changes. Worry about anticipation about when can I engage in my special interest, and worry and distress when the special interest is taken away. Specific phobias with unusual focus, like what Lee O'Connor mentioned. They're usually idiosyncratic phobias around sensory interests, and anxiety around sensory experiences. So these aren't in the DSM, but they're very important anxiety symptoms that we assess when we see kids in the office and that we try to capture and that are a target of treatment. So even though they're intricately linked with autism, we're still viewing them as separate. And this is a study by Connor Kearns, and she looked at the prevalence of DSM and ambiguous anxiety symptoms. These are 59 children, 7 to 17 years old, with an IQ above 70. And as you can see, she found that 15% of this sample had only the ambiguous anxiety, so only the anxiety that was related to the autism. 17% had DSM anxiety. About a third had no anxiety, and a third had both. So this is very important for assessment when thinking about, is the individual I'm working with or reviewing or caring for anxious, and if so, what types of anxiety are there? There's the traditional diagnoses, and then there's the autism-related symptoms. And there's a lot of triggers, right? We talked about all the triggers that can cause anxiety. So one of the biggest ones is the educational or other demands on the individual are greater than the support system available. And this is most common in the school setting, right? There's something, at least in Maryland, about services in that as soon as the child is doing well, it's time to have an IEP meeting and take away the services, right? There's something wrong with that picture. So it's when the demands and the expectations exceed the supports. But it's also at home, right? Sometimes parents think, she's 13 now, she should be able to do this, and they put all these expectations. And the individual can't. It's not a won't, it's a can't. And I think working with parents to help differentiate the can't or won't. We heard from Dr. King about pain or discomfort or medical conditions causing an uncomfortable feeling. Kids don't know how to describe it. It can cause anxiety. Medication side effects, right? Anticonvulsants, benzodiazepines, different classes of medicines can cause anxiety. Just the stress of having some autism symptoms. So there's some kids that I see with autism, they don't have trouble with change, or they don't have a lot of sensory issues. But then there are other kids that have it all, right? So sometimes the ASD symptoms are stressful, parental stress, and many adverse life events, such as bullying, change in school, lack of friends. Something as simple to us as, most kids are jumping up and down when there's snow days, 3 days of no school. For kids with autism, this is the major source of anxiety, right? They're home, the routine has changed, and the behavior starts. So lots of stresses in their lives and can trigger anxiety. So when we think about what's causing the anxiety, I think we're very early in our research, but I want to mention 3 psychological processes that we think might increase risk for anxiety. And each of these psychological risk factors is more pronounced in kids with autism and is hypothesized to have a neural basis. So the first is executive function deficits, right? These are higher in kids with ASD. Executive function deficits refer to, executive functions are kind of a coordinated set of functions that help you with planning and organizing your behavior in new situations. And so we know that kids with ASD have more executive dysfunction than typical individuals, which makes it hard to adapt to new situations. And probably the one factor amongst all the executive functions that's been linked to anxiety is inflexibility, the cognitive rigidity, right? When you think about how do we get rid of our anxious thoughts, we're able to shift them, right? Therapy forces you to shift your anxious thoughts. That's what cognitive restructuring is. Kids with ASD can get stuck, and they can't get unstuck from their negative thinking. Emotion dysregulation is another psychological process that's higher, more pronounced in kids with ASD, and Dr. Lerner talked about that this morning. The quick to react is emotion dysregulation, but shutting down is another form of emotion dysregulation. So it's the spectrum of irritability and explosiveness, but also withdrawing and being dysphoric and feeling depressed. So these kids are thought to have a higher risk of anxiety. And the last one is intolerance of uncertainty, and that's a new and emerging area of research. So uncertainty is a big factor. It's a big challenge in individuals on the autism spectrum, right? They don't know what's going to happen next. And intolerance of uncertainty, right? We all like some sense of predictability in our lives, right? You go on vacation for 3 weeks and you're yearning to go home after a while. We all like a sense of structure. Intolerance of uncertainty is the tendency to react negatively on an emotional, cognitive, and behavioral level to uncertain situations. So kids on the spectrum, individuals on the spectrum, some of them have trouble with the unknown, what lies ahead. And there's two types of uncertainty that we're thinking about. One is prospective uncertainty, what's going to happen next, and it could be the next hour, or the next day, or the weekend. And the second one is decision-making paralysis. I don't know what to do. I am stuck. And if you put this uncertainty together with inflexibility and emotion dysregulation, it's very hard to process stressful events, and it can lead to a lot of physiological arousal, worry, and anxiety. So intolerance of uncertainty, there's a lot of literature coming out showing that it's very much linked to both autism and anxiety, and this is what our group is working on, looking at intolerance of uncertainty as an inherent vulnerability factor for anxiety. So kids with autism who come with intolerance of uncertainty might have a higher risk of anxiety, and we recently published a paper showing that the kids who went through modified cognitive behavior therapy and had high levels of intolerance of uncertainty did not respond well to therapy. So this is an area that we are looking at targeting. And there are also parenting factors to consider. So there are higher rates of psychiatric symptoms in parents of children with ASD, social phobia, OCD, major depression are at the forefront. There's higher levels of caregiver stress, and when there's more stress, that affects parenting style. And we know that certain parenting styles give rise or result in a greater risk of anxiety in the individual and the child. The overprotective parenting style, just accommodating, doing everything for the child, not letting them use their skills, not exposing them to failing and then trying again, and then the intrusive and over-controlling parenting. So assessment, we had 2 excellent lectures on assessment this morning. Multi-informant. So anxiety is, for some, a very internalizing experience. In kids with ASD, it's very important to assess their self-report capacity. So I always say to my residents, my trainees, don't assume that just because you're seeing a person with autism that they can't tell you what's going on inside. Because some people really can. And even if they can't tell you in a very elaborate way, they're going to tell you in their own way. And it's really important to try. So the absence of evidence is an evidence of absence. You need to really try to ask and see where their capacities are. With the caregivers, the main piece is helping them disentangle what's anxiety, what's autism, and then it's very important to get information from all the other professionals working with the child, so teachers, therapists, in-home service workers, and so forth. And the method is, history, right? What we do is, mental health professionals, we take good solid history. If we can, we do observations. So we have a big playroom and a waiting room, and I always try to make a point of going out and even before calling the family, see what the child is doing out there. And then there's a lot of work being done on structured interviews and rating scales to help clinicians do a better job at measuring anxiety. So this is a very complicated process, but I think it is important to remember to get information from several different people and to try to use different methods to get that information. So what are the red flags? You heard about all the different types of anxiety, categorical, atypical. There are some common elements, some common presentations, regardless of the focus and the content. One is worries, right? The hallmark of anxiety is worry. and avoidance. Those are the two major symptoms of anxiety. Find out if the child or adolescent or young adult or adult can endorse worry. And if they can, you've got some self-report information, and if they're struggling with that, we look at behavior. So avoidance of certain activities, where is the anxiety occurring? Is it at home? Is it at school? Does it start in school but spill over at home because the arousal is so high? Fearful affect and clinginess. So one other point that I remember is every negative or irritable mood presentation is not anxiety, right? Sometimes you have to look for that scared face or the clinginess or the restlessness and the bodily tension, and increased vocalizations and repetitive behavior. So these are the behaviors that are representative of anxiety, but it's still kind of complicated because some of these overlap with autism. And so one thing to ask, we heard about this morning, is has there been a change from baseline? What's the individual's baseline? Has there been a change? Are the symptoms impairing? Is there a stressor? And I just always like to present this slide just to show the complicated overlap between autism spectrum disorders and anxiety. But again, if you get history from multiple informants, multiple methods, and you look at chronology, right? Baseline, change, impairment. Over time, it's easy to tease out. I can say in my practice, sometimes it takes 2 to 3 visits, to really get the information and tease this out. And it's important to do a comprehensive assessment so we know what we're working with and we can treat it the right way. But there are more complex presentations of anxiety. So anxiety never occurs alone. So there's anxiety, irritability, plus ADHD and tics. This is a common presentation in our clinic, right? The irritability could be from anxiety, it could be from something else. But the anxiety never travels alone. When I see a kid with autism, I know it's never only anxiety. There could be other presentations, anxiety, depression, and meltdowns. And you'll hear this afternoon a lot about aggression and severe behavior disorders. And there are multiple causes of behavioral issues in kids with autism. Psychiatric disorders, notably anxiety, notably depression, are a common cause of aggression and self-injury. Anxiety, ADHD, disruptive behavior, and school refusal. So these are just common phenotypic presentations that we see in our clinics. And that when we evaluate for anxiety, we also have to evaluate for all the other psychiatric presentations. And our challenge is to figure out what to treat first, right? Is the anxiety causing overwhelming demoralization that ends up evolving into depression? Is the anxiety making it look like the kid has bad ADHD, but it's really anxiety? So there's a lot of overlapping features, and it takes a while to disentangle it, and it takes a while to triage what's the most impairing psychiatric symptom and what we need to treat first. And then there are some dangerous presentations of anxiety that we don't think about. So irritability, aggression, and self-injury. So the young man that I mentioned with separation anxiety, right? That's a classic example of how anxiety can lead to an explosive outburst, an engagement of the acute response system, and an inpatient hospitalization. Very scary. Suicidality. We think it's always depression, but anxiety can cause overwhelming demoralization. So I see this a lot in kids who are higher functioning. Typical example is like on a Saturday when one of my seventh grade patients that I see, he has a history assignment, the mother is sitting, they're trying to do it, he can't get it right, he's erasing it again and again and again. This goes on for about an hour, and he's simmering and escalating and has a big meltdown. The mom calms him down, tries again, just full-blown escalation. I want to kill myself. It's Saturday at 6:00 p.m. and she doesn't know what to do. So we think of suicidality only related to depression, but it can happen with overwhelming stress and anxiety. And what happens in these dangerous situations is 911 is called, the police are called. I recently saw a young man, 16. They took him to the park on a field trip, and they knew there were a lot of things that made him anxious there, like kids on the swings. That movement just made him anxious. And there were other things that made him anxious. And they forgot to take or give him his as-needed dose of Zyprexa before he went to the park. Well, he went to the park, He had a major meltdown, disrobed, went after other children, but the police were called, and he was handcuffed. And they called the mother. She came. They took him to the ER, and they did not admit him because there was no bed available. So there was only 9 inpatient units in the country, and even though we have 2 in Maryland, ours are always full, right? We have always, whenever I send there's a kid, one of my patients in the ER, they're there for like 10 days. The mother said, I don't want to wait 10 days in the ER. And so she took him home, and then she called me, and I got him in the next day. So I just want to highlight that we don't think of these complex behavioral presentations as having psychiatric origins, but I really think we need to, because I know they have multifactorial etiologies, and given my focus on anxiety, I really see anxiety as being a major contributor to behavioral outbursts and severe danger to self and others. And so one very important thing to do that I do in my practice a lot is, even when I see kids with anxiety, I always do a risk assessment, right? Has your child ever had an 8 out of 8 anxiety experience? What's happened? What does that look like? What are we going to do if they completely decompensate? Let's come up with a plan. Let's be proactive while we're developing a treatment plan. So let's go through treatment. So there are many components of treatment: assessing the autism, treating contributing factors, therapy, and medication. So mild anxiety, if it's related to autism symptoms, let's work on making their routines and daily life a little easier. Give the kids a little more predictability, reduce sensory arousal, give them some noise-canceling headphones. A lot of patients in our waiting room are wearing noise-canceling headphones. Have a calming space at home. Increase communication, right? Anxiety often is associated with feeling powerless, right? Having no escape. Even kids who are low functioning need an escape, right? And there's ways of giving them tools to communicate, to say, you know, escape card, meaning I need a break, you know, helping them recognize what's going on. Also need to treat the contributing factors, academic, social, treating medical issues, other psychiatric disorders. So ADHD, I had a kid the other day who said, if I don't get my attention under control, I'm never going to get a job and I'm going to fail. So untreated ADHD can be a source of anxiety. And this kid was very insightful. He was worried about everything. He was worried about his future mainly. But he could make the connection that I need to treat my ADHD to perform better. And if I perform better, I might have a better outcome. Reducing parental anxiety, and I like to tell the families it's very important to have your child involved in wellness activities. And I say this to all the caregivers who bring their patients from group homes. The kids, the adults need to get outside, right? They need to have fresh air, they need to have exercise, they need to have good sleep hygiene. We need to encourage them, despite all their feeding challenges, to present them with, encourage them to make healthy food choices. So wellness is a big part of this. So there are specific therapies for anxiety. Modified cognitive behavior therapy has received the most attention, and there's moderate efficacy for this therapy. It is only for kids with an IQ of 70 or above. It treats social, generalized, and separation anxiety. So far we have data on short-term trials. And the modifications, the reason it's modified is because it's taking into account some of the challenges that individuals with ASD have. They might not be able to label their feelings very precisely. We might need to use general words for them like stress and upset. We might not do a lot of work trying to change their thought process because they get stuck. So instead we might do more exposure. We might teach them more breathing. And we try to incorporate all their special interests. You know, if they're over-focused on, dinosaurs, and we try to incorporate that into the therapy. So it's modified. And the data are looking very good. So far, those who have participated in treatment trials, about 50 to 80% of children and adolescents get better. This is comparable to the data in typically developing individuals. The challenge is the shortage of providers who will have specialized expertise in delivering this therapy. And the other challenge, which with any therapy in autism, is the generalization, which is the ability to take the tools that you learn in the office into your daily life. In terms of treating anxiety in individuals with autism and intellectual disability, we don't have much data, but I feel very fortunate at Kennedy Krieger to be working with some of the best behavioral psychologists in the country who know how to teach kids with intellectual disability to learn self-regulation strategies. Wonderful technique I love that they teach them is this hands down procedure where they sit in a chair and they repeat hands down with deep breathing, and it de-escalates them. I'm not doing it right, but they do it very well. Communication strategies, modeling, again, finding the right providers is critical. And based on the new literature that's emerging, there's also some novel treatments that we're studying. So treatments for executive dysfunction. So the main group, as I mentioned, people are doing this around the world. Lauren Kenworthy at Children's National is focusing on a treatment called Unstuck and On Target to help kids get unstuck on negative things or things in general so they can shift their thoughts. Emotion dysregulation, so Carla Mazeski and Susan White are doing a lot of work in mindfulness and other types of treatments for emotion dysregulation. And in tolerance of uncertainty, Jackie Rogers at Newcastle University in the UK just came out with a module called Coping with Uncertainty in Everyday Situations to target the intolerance of uncertainty. So as I mentioned, generalization. A few of us were all in San Francisco last week for the Autism Conference, and I love the Golden Gate Bridge. It's very hard for kids on the spectrum to take what they learn in the office and then apply it in day-to-day life. You can do a lot of work on how to stand up to bullies in the office, but then in a real life, in vivo situation, it's very difficult. And I think this is true for all the therapies that we prescribe, and I do think a future area of research is trying to develop therapies right in the community setting, so it's more naturalistic. So medications, so when to use medications? So first is moderate to severe anxiety, right? Not every kid can participate in therapy. The anxiety is too high. The psychologist will tell you, I can't do exposure work. The anxiety is too high. When there's severe behavioral issues, so there's a safety concern, right? Therapy therapy is great. It's new learning, it's durable, and it takes a long time. Right? So if you've got a dangerous situation here, we probably don't want to wait 12 weeks to reduce the aggression because people are going to get hurt. When anxiety isn't improving with the other treatments, and feasibility. So the reality is there's a shortage of child psychiatrists, child psychologists, occupational therapists, special ed teachers who understand mental health issues in the classroom. And so I can't tell a family, please drive 2 hours to see the CBT therapist or the behavioral psychologist once a week, because that's just remember, families of children with autism have multiple appointments every week, and there's a lot of parental stress. So we really have to think about all of that, and we have to think about, how equipped is the parent to be able to take these therapies in the clinic and help their child with those therapies outside the clinic. So in terms of medications, we generally use the same medications for anxiety that we use in typical individuals. The data on medications for anxiety in children and adolescents and young adults with autism are sparse, but that doesn't deter us from treating when we've got severe anxiety, when there's no other therapy providers, when there's danger. We monitor, we do a close, we monitor closely for side effects. We start with low doses and titrate, and we stay in touch with the families. We don't leave them hanging on a weekend. We give, when their kid's out of control on a Friday, they need to know that they have a plan if their kid gets out of control. These are the selective serotonin reuptake inhibitors. So although there are no specific data available, we do prescribe these medications, and we prescribe them carefully, and there are guidelines that have been written up in pediatrics. These are the same doses that are prescribed in typically developing children. We just start at lower doses. So in a typical kid, we might just start at 25 milligrams. But an individual with autism, we're going to take a liquid preparation, start with 12.5 milligrams. And sometimes kids on the spectrum or adults on the spectrum can't tolerate those medications, the SSRIs, so we treat anxiety-specific symptoms. So we can treat the insomnia, the arousal, we can treat behavioral dysregulation, the irritability, and we also treat situational anxiety. So a lot of times families will say, we have a wedding coming up, or the patient's sister is graduating and we all want to go. So we think about medications on an as-needed basis so the entire family can enjoy that event. And that's really important for them to be able to have that experience and to feel part of a community. And sometimes multiple medications are needed, and it's not a bad thing, right? Because sometimes the medications are treating different targets, and if the individual is working with a psychiatrist or a developmental pediatrician who really understands and has characterized the anxiety well, and is monitoring closely and prescribing carefully, sometimes, a medication for sleep and a medication to target the arousal will cut down on the anxiety 50%. The therapies will be more effective. So treatment requires a multi-pronged approach with multiple different providers, increasing communication, addressing school issues, providing structure, reducing parental accommodation, anxiety-specific therapy, and medication. I mean, this anxiety that we see in this population can be wrapped around different parts of life, in school, in social situations, so we really have to come at it from all angles. And I don't think one treatment arm alone is sufficient. This is not what we sometimes do in typically developing kids who come in. They have generalized anxiety disorder. We say, look, there's 10 CBT psychologists who in your area, so just look at your insurance plan and pick one, and I'm going to start you on sertraline 25 milligrams and come back in a month. This doesn't work like this, okay? This is complicated, and it requires very close attention and follow-up. The other thing I wanted to mention is, as a clinician, I've learned to be aggressive, meaning to go after the anxiety in terms of looking for it, right? If you don't look for it, you're not going to find it. Right? You're going to assume that the psychiatric stuff or the behavior stuff on the surface is something else. Go through a detailed, comprehensive evaluation and find it, but also be realistic. We may never eliminate all the anxiety, right, that kids have, right? Their ASD symptoms just inherently predispose some of those individuals. But we have to make functioning better. They will live more productive, more satisfying, more meaningful lives, more comfortable lives if their stress level is down, if they feel better, if they can engage with others, they can participate in some meaningful activities. So I think it's important to be aggressive with treatment, but we have to set measurable goals and we have to be realistic about it. This is a work in progress, our understanding of anxiety in terms of diagnosing and treating it. I've given you a lot of kind of anchor points to hold on to, but we have a lot of work to do in terms of understanding what it looks like, how best we can measure it, how do we develop treatments, better treatments for those with intellectual disability, how can we generalize treatments, how can we develop treatments in the schools, right? I think it would be perfect for kids with autism, teenagers, to get treatment for their mental health condition in the school where the anxiety is occurring. And we definitely need more medication studies and combined medication and therapy studies. There are many resources out there for parents and for clinicians. Really speaks to how important this condition is, how it's viewed and conceptualized as a very distinct psychiatric problem that has a major impact on functioning throughout life. And I also want to mention that the number of books, in addition to research articles and other clinical resources, the number of just books and manuals for treating anxiety and understanding anxiety has increased. So in summary, I hope you walk away with understanding that anxiety is highly prevalent, debilitating, very important to diagnose, and to understand its origins, and to think about multidisciplinary treatments over the long term to help relieve suffering. So thank you.